think it has to do with teaching and availability to practitioners who are interested in endometriosis and look for it on ultrasound.
Yeah, okay, thanks.
Yeah, thank you. So the point of linking ultrasound and surgery is, of course, like we said, to improve the information and consent process for the patients and also for the multidisciplinary team, that we can optimize the surgical planning. And then by that, we can streamline surgery by making sure that we have all the equipment ready for the whole team and provide adequate surgery for our patients and also prevent possible surgical complications, or at least try and foresee them, the potential, and to inform our patients about this. When we talk about endometriosis surgery on a daily basis, the superficial lesions like this one, it's easy to handle and it doesn't require that advanced skill level. However, we also do ureterolysis on a daily basis as well as we do excisional surgery, and it's kind of like the basic step that we need to know to do this type of surgery. But for the more advanced cases, when we talk about deep endometriosis, which is the focus today, we're talking mainly about looking with ultrasound for urinary tract endometriosis on the bladder and the ureter, although it's very rare, vaginal endometriosis and bladder endometriosis. So I'll show you some cases of that today. There are several surgical scoring systems, and I think the hashtag NCN classification can say something about disease complexity before surgery with ultrasound, and it can also give us then a pinpoint of the level of surgical complexity that we would expect for our surgery, but also in terms of informing patients of what we will actually do. So this can be done preoperatively with ultrasound, as shown by Hodelist, and also we can describe our findings during surgery and the results after surgery. And why is that important? I think it's important in our communication with our local hospitals, as we're a tertiary referral center for endometriosis, and I think it's also important to document for our patients what we've actually done and what we treated, and also for clinical research purposes.
So historically, the original NZN system was a surgical, almost mapping system where you would then have an overview of what was seen at the time of surgery. Yeah. And then I know that Kirkstein and Huddless then took a step back and then have obviously introduced the hashtag NZN. Is it something that's used only by surgeons who do ultrasound scans? Or is it sonologists themselves that are embracing the hashtag NZN?
I think it's a process because in our department it's slowly people are coming on board for the utility of using this classification. But I think it's something that can definitely be used by sonologists and laparoscopic surgeons and laparoscopic surgeons who do sonography as well. I think it's useful. So going on to the urinary tract and just showing you a case of bladder endometriosis. So most of the cases of bladder endometriosis is located in the bladder base and the bladder dome. And of course, the bladder base lesions are more challenging to handle laparoscopically because they are closer to the ureteric outlets. So that poses a bigger challenge for us. This is a case of bladder endometriosis where you can see the uterus, the fallopian tube, and the uterus kind of twisted, and the bladder lesion is in the base, close to the front of the isthmus of the uterus. And then there's a balloon catheter above that you might mistake for the lesion, but it's not. And this was a woman in her 30s who came with us with infertility, and she didn't have any bladder symptoms, which is quite typical for bladder endometriosis. And she was referred for surgery. But we did, of course, the ultrasound beforehand, and that's when we discovered the bladder lesion first time. And you can see in the mid-sagittal plane the relation to the ureter, and you can see that quite well. But also doing the transverse scan is important to see the distance to the ureteric outlets. But in our department, we also perform cystoscopy as well. I don't know how you do it in Sydney.
And with this sort of case where you've got sparing of the ureters, is that something that you would do, or you'd still involve the urologists?
We would involve the urologist in particular in cases where it's the bladder base, but our challenge is, again, that the urologists, they work mainly on robot, and we are straight stick surgeons at the moment, although we're converting to robot slowly. And so they're not used to treating patients necessarily with normal laparoscopy. So then they sometimes instruct us how to do it, and so they're watching us, and they tell us what to do, and then we do it. Yeah.
And more broadly speaking, more from a surgical perspective, do you electively or prophylactically use ureteric catheters, either luminous or non-luminous?
Not standard, but in this case we did, because the bladder lesion was so close to the ureteric orifices. But standard we don't, because we prefer to see the peristalsis and the normal movement of the ureter. I don't know what you prefer in your department.
I think for the complex cases, we tend to, particularly not so much for anterior compartment, but certainly for posterior compartment, we put in ureteric catheters. If we have the luxury of having access to the luminous catheters as well, that's quite helpful. I don't think it necessarily makes a difference to the overall rate of injury, but I think it's good for acknowledgement of the injury.
Yeah.
So you're more likely to be able to fix it at the time of the surgery rather than waiting for urine to be leaking per vaginum, for example.
Yeah. Sorry, I didn't catch that you said luminous catheters, because we haven't tried that. It's many years ago we had it, but it was only a test, but it's not standard, so we just use standard catheters then. Yeah. Okay, so you can also use the sliding sign for bladder endometriosis that we have for bowel endometriosis, and we measure the lesion in the 3 diameters as suggested by the IDEA consensus. So here is a laparoscopic image of the bladder lesion that was excised, and in this case we used catheters because of the proximity, as you can see here, to the ureteric outlets, and we closed the bladder in 2 layers. So this procedure we actually did ourselves, but the urologist was basically just coaching us. Yeah. And then the lesion was about 3 centimeters in diameter, and she had a catheter for 10 days, and we always perform a cystography first before we remove it, and then the stents were removed after 4 weeks. When we talk about urethral endometriosis, this is an image from the IDEA consensus, just illustrating that it's the proximal part of the ureter that we can see from the bladder up to the urinary artery that we visualize. And it's quite rare to catch a hydroureter, but that's what we look for. It's definitely feasible to learn for a general gynecologist after 40 to 50 examinations how to identify the ureters. So it's definitely okay even for laparoscopic surgeons who don't do scans all the time to learn it. And this is what we want to see, a hydroureter, and hopefully that we don't see hydronephrosis by doing an abdominal scan. But I think it's important to do an abdominal scan in any case and look at the kidneys when there are cases of deep endometriosis.
I'll just do a poll. So in the audience, when someone performs an ultrasound to assess for endometriosis, hands up those that also always look at the kidneys on a transabdominal scan. Very impressive. So that's probably more than half the room, which is very good. Yeah. And I think you're right. I think the distal third of the ureter, unless you've got a uterosacral lesion that's extending into the parametrium, and if we have time, I'll show a slide of that later on. I often find that the distal third of the ureter is often normal.
Yeah.
And then as you follow the ureter cephalically, you can see its relationship to the pelvic sidewall with the ovary. Yeah. And more often than not, if I see some degree of hydroureter, it's usually above that lower third.
Yeah.
So what's your experience?
Yeah, I fully agree, and that's the challenge, and that's why I didn't have a proximal hydroureter, because I think it's quite rare. Yeah. And it's mainly the challenge of the uterosacral ligaments that's higher up that the lesion is. I'll show you a video on that. Yeah.
Thanks.
Yeah. Okay, so what is the normal diameter of the ureter? Well, Cafagna has found that its urethral dilatation occurs when the ureter is measured more than 6 millimeters in diameter. This is a case of extrinsic endometriosis. It can be either intrinsic, having endometriosis in the actual muscular layer of the ureter, or extrinsic, as in this case, which was quite severe. But just to illustrate that the surgery can be just as challenging, although it's not requiring a reimplantation. And this we do without a urologist, but we're trying to lateralize the ureter from the sacrouterine ligament. So it's an example of what you actually said, George. And you can see the apple core shaped shape of the ureter as well. So we continue then using a micro scissor to remove the surrounding fibrosis. And in this case, we didn't use a stent because we'd like to see the normal peristalsis and movement of the ureter. And also we find that a ureteric stent gives us more stiffness, and the tissue just looks different as well while we're doing the surgery.
And then in that case where you've got that almost extrinsic compression, so it would excise that fibrotic reaction and then attempt to lateralize the ureter.
Yes.
And then when you feel that subjectively the ureter is mobile, obviously then excise the disease. Yeah. And then is anything else done to that ureter?
We tried to make like a tunnel all the way to the bladder so we can see the communication to the bladder. So the insertion of the ureter to make sure that there is no disease that we left so there aren't any fibrosis. And then we leave the ureter. We don't put any stents in afterwards either. Then we just hope for the best. And
in cases where you do find hydroureter, do you always, or do you consider looking at renal function pre-surgically?
Yes, it depends on the severity of the hydroureter. We also do we rely mainly on ultrasound, but we also do MRI mainly because of those challenges with the ureter and not seeing that distal 2/3 of the ureter. But and then I think it's it's important to just make sure that we can treat it.
Yeah. But it's interesting what you said before about the idea of robotics versus straight stick surgery, and it's the same for us in Sydney, where almost every urologist exclusively uses the robots, and so unless you are also trained to do something robotically, they're quite reluctant to do something with the laparoscope, because they don't feel as comfortable as compared to sitting behind the console. And I think that in of itself can create issues, because obviously if someone's performing a surgical procedure they do all the time, but using a modality they're not comfortable with, then that may result in a higher complication rate as well. So I think it's important to have some sort of synergy with the surgical approach with the team that you're working with to get the best outcomes as well.
Yeah, definitely. I think with the colorectal team, we have a set group of surgeons who are interested, and we kind of taught them about endometriosis, and they have a bigger understanding of the procedure. And we also do disc excisions, and they come on board to that, and it's taken some time, but I think we have a good collaboration. The challenge with the urologist for us is logistics. I don't know if it's like this for you in other hospitals, but they're located somewhere else, so it's not so easy. The collaboration can be a bit more difficult because of that. But, Okay, so vaginal endometriosis rarely comes alone. So this is the case of rectovaginal endometriosis. You can't see that there's a vaginal lesion, and you can't see a rectal lesion, but you can suspect it because the bowel is pulled up to the isthmus. And the ultrasound scan showed that there was a low lesion that was about 8 centimeters from the anal verge, and it affected the bowel and the vagina. And there was a negative sliding sign.
So when you say rectovaginal lesion, do you mean a lesion within the rectovaginal septum, or do you mean concurrent vaginal and rectal disease?
I think that's up for debate, and I understand our friend Leonardo is looking at that. But I think when I talk about rectovaginal disease, it's actually above the rectovaginal septum in most cases, and actual rectal vaginal septal disease is quite rare because it's at the level of the lip of the cervix and it's distal to that. And that's extremely rare that we have those cases, at least in Norway. I know that they do very low lesions and treat that in France with the Roy technique, but we've been there, but we don't do any of those cases because somehow we don't have such low lesions.
And that was an important part of the consensus statement, and I'm sure Stefano can attest to this. There was a lot of debate about this concept of defining rectovaginal septum and rectovaginal septal endometriosis. And so in of itself, it's a specific anatomical location, and the upper rectovaginal septum begins at the lowermost point of the pouch of Douglas, or the rectouterine pouch, and then that fibrous or connective tissue band inserts distally into the perineal body. And when you do ultrasound scans and then you follow up those patients that have got rectal disease and the septum is spared, almost always, when you get below the level of the lesion at surgery and you open up the rectovaginal space, the rectovaginal space which contains the septum is almost always spared. So I think the idea of pure rectovaginal septal endometriosis, I think, is rare. Yeah. I think it can exist with vaginal disease that potentially invades posteriorly, or rectal disease that invades anteriorly. But I mean, certainly in our experience, we find that on ultrasound and at surgery, the rectovaginal septum, then that rectovaginal space at surgery is almost always clear. And that's always important, because then you get below the level of the rectal lesion, you've normalized the anatomy, and then you can make a decision about whether you're going to perform a disectomy. You've cleared that disease inferiorly, so that if they want to do a segmental resection, it's possible to get the linear stapler below the level of that rectal lesion itself. So that distinction between rectovaginal septal endometriosis, which I think is rare. We're happy to take comments from the floor, but I think it's an important thing to know about surgically. Conversely, in the cases where there is rectovaginal septal endometriosis, I think those patients are more likely to have higher complication rates, such as potential fistulae, or maybe even a leak if you've got something that's happening from the point of view of primary anastomosis.
Yeah, definitely. And I think using that rectovaginal septum, it's equivalent to Denoliers fascia. Sorry, my French is not very good, but and it kind of pinpoints us when we do the dissection to find that healthy layer. Sometimes, like you say, to go for those low lesions and find the anatomy and do the dissection, then it's definitely helpful that it's there, and usually it's healthy. But yeah, I agree. Yeah. Okay, so we're now detaching the rectum from the torus uterinus, and then we go on to removing the vaginal endometriosis. So in this case, we did both a segmental resection and we did opening of the vagina, and there is an increased risk then of a rectovaginal fistula. Here you can see that there's endometriosis tissue, and we're trying to find healthy tissue that we can suture. Again, just showing that there's endometriotic tissue emptying from the vaginal area. Just an example of bowel endometriosis. So this was the image that met us during surgery, and in local hospitals, they might not pick up that there is a bowel lesion at all unless you look closely and you palpate the rectum, and then you can see the invagination in the midline here. But still, we didn't know the size of the lesion, but we did the ultrasound beforehand, as we should. And it was a 3 centimeters lesion, and we planned for a segmental resection, which this lady underwent.
And the decision preoperatively, because I always have this, I suppose, argument where I wonder how much, and again, we've touched on this before in other meetings, but how much of the ultrasound influences the decision of the colorectal surgeon?
It's mainly us who say this is based on the ultrasound image. Then we say, okay, we plan for this type of either disc or shaving or segmental resection. So it's us who plan the surgery together with the patient, and then we tell this colorectal team this is what we want to do. So that's the order of the order of how we do things. But if the lesion is very low, then we of course involve them at an early stage to prep the patient for a possible temporary stoma. But I think that's also a debate nowadays in the colorectal environment, even for treating cancer patients, that they want to reduce the use of stomas because that also has complications with it, and in particular because endometriosis affects healthy women, and the cancer patient group is completely different, but still they're thinking about reducing the rate of stomas for cancer patients as well. So
And
That's interesting.
And I think the ultrasound can be helpful. So if you've got a lesion that's more than 3 centimetres, or if you've got multifocal disease, then I think that can influence the decision for a segmental resection or not. So I think that can be really helpful. One of the things that I struggle with is, and we were talking about this over dinner the other night, I was talking to Carla about this, is sometimes the lesion that's measured, to me, seems to be smaller than the lesion that you palpate at surgery. And I wonder whether that hypoechoic area that we measure within the muscularis of the anterior muscularis of the rectal wall somewhat underrepresents the true size of the fibrotic reaction.
the stapler distally.
And so now above that level of your linear stapler is the lesion itself?
Yes, so now you will see the lesion, and like you say, it appears bigger.
There it is.
Now
there.
we zoomed in, of course, but that was the lesion that was 3 centimeters that I showed on ultrasound.
But you're right, it's impressive how, because you start the procedure and obviously you've got complete distortion of anatomy, the rectum's hitched up either to the back of the cervix or in significant cases you've got an anteverted retroflex uterus and the disease is hitched to the back of the uterus at the fundus posteriorly. And then as you mobilize that, as you say, ureters, pararectal spaces, central disease off the back of the cervix, off the back of the uterus. And it's amazing how much mobility you can get, which enables you to get good clearance inferiorly, and obviously then they mobilize that rectum superiorly, so you've got obviously no tension at the site of the reanastomosis site. So I think it's really important that the normalization of the anatomy from a surgical perspective is, for me, the key to success. And often that is the most difficult part of the surgery. And once you've normalized your anatomy, then you can excise your disease and hand over to the bowel team. But that part of the surgery, I think, is really critical in getting below the level of the most inferior rectal lesion, opening up that rectovaginal space, getting clearance inferiorly so that you can see, as on your previous slide, when they bring in that linear stapler, which it takes up the whole screen, there's good clearance below.
Yeah. Definitely. I think that's the challenge to prep the area for the surgeon.
Absolutely.
So we're doing all the hard work and they come in and
I know.
save
I
us.
always say to my friend who's the colorectal, I just say to him, I make you look so good.
Okay, so there are 2 parameters that are particularly important to know, and that's the lesion to anal verge distance, but also the lesion size. And that's what the general recommendation is. And what I mean by lesion to anal verge distance is the inferior border of the bowel lesion down to the anal verge. And this distance says something about the risk of anastomotic leakage. So if the lesion is at the level of 5 to 8 centimeters from the anal verge, then we start thinking about a temporary stoma in our department. So we did a study and suggested methods on how to measure this distance with ultrasound. And in terms of lesion size and surgical procedure, in general, discoid excision and shaving is safe for lesions that are less than 3 centimeters, and for lesions that are larger than 3 centimeters, segmental resection is what we usually perform. And then definitely ultrasound can be useful, and we measure the lesion size according to the idea consensus that we've done in our study, and we found good correlation to the post-surgical specimen.
When you go on the previous slide, can you just explain to the audience how do you measure the distance from the most inferior aspect or the most caudal aspect of the inferior lesion or the solitary lesion if there's not multifocal disease to the anal verge? How do you do that?
There are 2 methods because it depends on where the location of the lesion is. I don't have an image of that today, but if the lesion is near to the rectovaginal septum that we talked about, then we introduce the probe into the vagina, transvaginally, not transrectally, and then take the tip of the distal part of the probe up to the level of the inferior border of the lesion, and then visualize the anal verge during the examination in the gynae chair, and then put my finger on the probe at the estimated level of the anal verge whilst looking at the screen, and then I pull it out, and then I measure the distance. So that's for lower lesions. But if there are lesions that are higher, which is quite common, around 10 to 12 centimeters from the anal verge, I think most of our lesions are there, then I would measure the distance from the inferior border of the lesion down to the cervix, so I have some anatomy, and then I would put the probe up to the level of the cervix and then visualize the anal verge again, and then pull the probe out with my finger on the estimated anal verge and measure them and add that together.
Add them together. Okay. And some people advocate doing a transrectal scan and then putting the tip of the probe up against the inferior margin of that rectal lesion, and then a finger at the anal verge, taking out and then measuring that distance.
And that was what was proposed in the idea consensus as well. I think it works well for lower lesions, but not for higher lesions because it's quite an uncomfortable examination. So that's why we proposed the transvaginal route.
Okay, thanks.
So this was the image in a bowel case that we saw, and it's not complete obliteration of the pelvis, but still the isthmus is, the rectum is pulled up to the isthmus and at the back of the uterus. And the ultrasound scan showed that there was a bowel lesion, and with a negative sliding sign, and this was at the level of 12 centimeters from the anal verge.
See, if we're in the southern hemisphere, that image would be upside down.
Yes, so I'm just trying to, this is the way we scan in Norway, but yeah. So the bladder is at the front where you see the number, then it's the uterus, and then it's the lesion, just to orientate yourself. Yeah, sorry, I didn't. Sorry, if I can point to the lesion. I don't have a pointer, but I can point here.
Yeah, point on the screen.
Oh, sorry. I can't start the video again, I think. But, sorry.
Is it possible to run that slide again?
This is the bladder. That's the uterus. And this is the lesion. So that's how we scan in Norway and in Austria, as far as I know. Yeah. Yeah, very excellent, very good. Yeah, I agreed. Thank you. Yeah.
The right way? Come on.
Yeah. Yeah.
I've got to come there.
You're upside
I've got to
down.
come and learn the right way. My gosh.
Yeah. Okay, so this is the image that we see during surgery. You can see the fibrosis. I'll just go on to point out, because you can't see the lesion very obviously here, but this is the fibrosis and the lesion that we saw during surgery. So it's not possible for us to estimate the lesion while we're doing the surgery, I think. And that's why we need ultrasound. So during surgery, we go again pararectally up to the lesion that's attached to the uterus. And just to give you an overview image of what we actually see during surgery, the camera will zoom out. And